1983 saya kembali dari Belanda, kemudian kami bekerja berempat, Profesor Basuki, Dr. Muhammad Said Darmadipura, Dr. Umar Kasan, dan saya sendiri. Lalu kami mulai bekerja, tahun 84 dibentuklah grup bedah saraf. Itulah asal mula kelahirannya. Jadi kalau grup bedah saraf itu di mana-mana ada. Dokter bedah saraf yang ahli pun banyak. Kami punya satu kekuatan di sini bahwa grup ini berpijak dari universitas. Universitas itu landasannya adalah riset. Oleh karena itu kita namakan Institute. Neuroscience, ada science di situ. Ilmu yang mempelajari secara mendalam tentang sistem saraf, baik itu penyakitnya maupun teknik menanganinya. Itu yang menjadi kunci daripada SNE ini, bahwa kita didasari oleh perilaku akademik. Kita dapat memberikan yang terbaik kepada masyarakat dalam bidang bedah saraf. Jadi SNE itu sebetulnya adalah kristalisasi dari pemikiran para ahli tadi yang ada, karena masing-masing anggota SNE itu punya kelebihan sendiri-sendiri.
Setiap anak punya kesempatan dan punya harapan untuk jadi lebih baik. SNE punya satu divisi pediatrik yang dapat menolong anak-anak Indonesia untuk meningkatkan kualitas hidupnya, mendapatkan pendidikan, menjadi anak-anak yang berkualitas dan menjadi mereka generasi penerus yang kelak akan menjadi pengganti-pengganti kita dengan kualitas yang terbaik.
Kalau SNE bisa menggalang Lions Club, Lions model-model yang nasional, apalagi kalau pemerintah pusat bisa didorong untuk mendirikan Pediatric Brain Foundation, itu anak-anak dengan kelainan otak yang sifatnya kongenital akan sangat tertolong.
Jadi tulang belakang itu dia adalah struktur yang melindungi sumsum dan saraf yang luar. Jadi dia sebagai support, sebagai penahan supaya tidak terjadi pada cedera pada sumsum maupun saraf.
Pengalaman yang paling berkesan, yang menyenangkan itu adalah apabila kita bisa memberikan sesuatu kegunaan pada pasien tentunya, dan melihat pasien itu tersenyum, itu kita akan sangat merasa gembira di situ.
Saya akan sangat senang, dan itu merupakan cita-cita saya, bisa memberikan pelayanan sesuai dengan kebutuhan pasien, sehingga pasien bisa terbebas dari rasa sakitnya, dari penyakitnya. Itulah. Karena itulah kita menghimpun diri dalam Surabaya Neurosurgeon Institute. Tujuannya adalah agar kita bisa memberikan layanan pada pasien itu sesuai dengan standar internasional, memanfaatkan teknologi modern yang sesuai dengan peruntukannya, kemudian juga sistem pelayanan yang terstruktur dan terstandar yang diakui oleh dunia internasional.
Setiap pasien adalah istimewa. Setiap pasien adalah makhluk-makhluk istimewa yang kita diberi kesempatan oleh Tuhan untuk membantu mereka.
Pasien di mana dalam kondisi koma karena ada perdarahan di otak, karena ada aneurisma yang pecah sehingga kesadarannya menurun sekali. Kemudian datang ke kita dan kita otomatis kita anjurkan untuk dilakukan suatu tindakan. Karena usianya sudah tua, maka pilihan yang paling baik pada pasien tersebut adalah kateterisasi otak atau endovaskuler. Ya. Jadi kita bisa lakukan tindakan dengan minimal invasif tanpa operasi.
Pasien stroke itu menyebabkan angka kecacatan dan kematian paling tinggi.
Kemajuan teknologi di dalam saraf adalah ditemukannya stereotaktis.
Dengan adanya teknik yang baru ini, dengan stereotaktik neurosurgery ini, kita berharap ini merupakan menjadi harapan yang sangat baru untuk pasien, sehingga pasien bisa meningkat kualitas hidupnya.
Pasien kecelakaan lalu lintas datang ke UGD dengan kesadaran yang sangat rendah sekali. Itu saya harus segera menangani mereka dengan cepat, bahkan dengan bantuan dokter-dokter yang lain. Dengan RW retinal circulation itu juga harus dilakukan secepat mungkin tanpa adanya kesalahan sedikit pun.
Ada hubungan yang sangat erat antara pendidikan dengan pelayanan.
Dengan teknik operasi yang baru, metode pengobatan yang baru yang kita jalankan, insya Allah akan memberikan manfaat lebih bagi pasien.
harapan selalu ada buat kita karena kita mengedepankan kejujuran. 1983 saya kembali dari Belanda, kemudian kami bekerja berempat, Profesor Basuki, Dr. Muhammad Saidar Madipura, Dr. Umar Kasan, dan saya sendiri. Lalu kami mulai bekerja tahun 84, dibentuklah grup bedah saraf. Itulah asal mula kelahirannya. Jadi kalau grup bedah saraf itu di mana-mana ada. Dokter bedah saraf yang ahli pun banyak. Kami punya satu kekuatan di sini bahwa grup ini berpijak dari universitas. Universitas itu landasannya adalah riset. Oleh karena itu kita namakan Institute. Neuroscience, ada science di situ. Ilmu yang mempelajari secara mendalam tentang sistem saraf, baik itu penyakitnya maupun teknik menanganinya. Itu yang menjadi kunci daripada SNE ini, bahwa kita didasari oleh perilaku akademik. Kita dapat memberikan yang terbaik kepada masyarakat dalam bidang bedah saraf. Jadi SNE itu sebetulnya adalah kristalisasi dari pemikiran para ahli tadi yang ada, karena masing-masing anggota SNE itu punya kelebihan sendiri-sendiri.
Setiap anak punya kesempatan dan punya harapan untuk jadi lebih baik. SNE punya satu divisi pediatrik yang dapat menolong anak-anak Indonesia untuk meningkatkan kualitas hidupnya, mendapatkan pendidikan, menjadi anak-anak yang berkualitas dan menjadi mereka generasi penerus yang kelak akan menjadi pengganti-pengganti kita dengan kualitas yang terbaik.
Kalau SNE bisa menggalang Lions Club, Lions model-model yang nasional, apalagi kalau pemerintah pusat bisa didorong untuk mendirikan Pediatric Brain Foundation, itu anak-anak dengan kelainan otak yang sifatnya kongenital akan sangat tertolong.
Jadi tulang belakang itu dia adalah struktur yang melindungi sumsum dan saraf yang luar. Jadi dia sebagai support, sebagai penahan supaya tidak terjadi cedera pada sumsum maupun saraf.
Pengalaman yang paling berkesan, yang menyenangkan itu adalah apabila kita bisa memberikan sesuatu kegunaan pada pasien tentunya, dan melihat pasien itu tersenyum, itu kita akan sangat merasa gembira di situ.
Saya akan sangat senang, dan itu merupakan cita-cita saya, bisa memberikan pelayanan sesuai dengan kebutuhan pasien, sehingga pasien bisa terbebas dari rasa sakitnya, dari penyakitnya. Itulah. Karena itulah kita menghimpun diri dalam Surabaya Neurosurgeon Institute. Tujuannya adalah agar kita bisa memberikan layanan pada pasien itu sesuai dengan standar internasional, memanfaatkan teknologi modern yang sesuai dengan peruntukannya, kemudian juga sistem pelayanan yang terstruktur dan terstandar yang diakui oleh dunia internasional.
Setiap pasien adalah istimewa. Setiap pasien adalah makhluk-makhluk istimewa yang kita diberi kesempatan oleh Tuhan untuk membantu mereka.
Pasien di mana dalam kondisi koma karena ada perdarahan di otak, karena ada aneurisma yang pecah sehingga kesadarannya menurun sekali. Kemudian datang ke kita dan kita otomatis kita anjurkan untuk dilakukan suatu tindakan. Karena usianya sudah tua, maka pilihan yang paling baik pada pasien tersebut adalah kateterisasi otak atau endovaskuler. Ya. Jadi kita bisa lakukan tindakan dengan minimal invasif tanpa operasi.
Pasien stroke itu menyebabkan angka kecacatan dan kematian paling tinggi.
Kemajuan teknologi di bidang saraf adalah ditemukannya stereotaktis.
Dengan adanya teknik yang baru ini, dengan stereotaktik neurosurgery ini, kita berharap ini merupakan menjadi harapan yang sangat baru untuk pasien, sehingga pasien bisa meningkat kualitas hidupnya.
Pasien kecelakaan lalu lintas datang ke UGD dengan kesadaran yang sangat rendah sekali. Itu saya harus segera menangani mereka dengan cepat, bahkan dengan bantuan dokter-dokter yang lain. Dengan RW retinal circulation itu juga harus dilakukan secepat mungkin tanpa adanya kesalahan sedikit pun.
Ada hubungan yang sangat erat antara pendidikan dengan pelayanan.
Dengan teknik operasi yang baru, metode pengobatan yang baru yang kita jalankan, insya Allah akan memberikan manfaat lebih bagi pasien.
harapan selalu ada buat kita karena kita mengedepankan kejujuran.
ya. Bismillahirrahmanirrahim. The Honorable Rector of Universitas Airlangga, to whom represented by Vice Rector of Universitas Airlangga for Internationalization, Digitalization, and Information, Dr. Muhammad Miftahus Surur, MD, PhD. The Honorable Dean of Faculty of Medicine, Universitas Airlangga, Professor Budi Santoso, MD, PhD. The Honorable all Vice Deans of Faculty of Medicine, Universitas Airlangga, the Honorable Dr. Ahmad Husnur Ramdoni, MD, PhD, the Honorable Dr. Hani Badriah Hidayati, MD, PhD, the Honorable Dr. Sulistiawati, MD, PhD, the Honorable Director of Dr. Soetomo General Academic Hospital, Dr. Joni Wahyuadi, MD, PhD, or the representative, the Honorable Director of Universitas Airlangga Hospital, Professor Nasronuddin, MD, PhD, the Honorable Chief of International Unit Faculty of Medicine, Universitas Airlangga, Dr. Asra Al-Fauzi, MD, PhD, the Honorable Head of Neurosurgery Department, Faculty of Medicine, Universitas Airlangga, Dr. Soetomo General Academic Hospital, Dr. Muhammad Arifin Parendrengi, MD, PhD. The Honorable former Head of Neurosurgery Department, Dr. Agus Turhan, MD, PhD. The Honorable Professor of Neurosurgery Department, Professor Abdul Hafid Bajamal, MD, PhD. The Honorable Professor P. Sarat Chandra, MD, as the Adjunct Professor of Neurosurgery Department, Faculty of Medicine, Universitas Airlangga, Dr. Soetomo General Academic Hospital. The Honorable Senior Staff Members of the Neurosurgery Department, the Honorable Senior Staff Members of Faculty of Medicine, Universitas Airlangga, and Dr. Soetomo General Academic Hospital, dearest residents, and also to our distinguished guests. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Alhamdulillahirabbil alamin. Let us praise Allah Subhanahu wa Ta'ala. Because of His blessings, we can be healthy, in a good condition, and participate in this event. Salawat and salam may always be delivered to our beloved Prophet Muhammad Sallallahu Alaihi Wasallam. This morning, 12 October 2021, we are in the Adjunct Professor Inauguration Ceremony, organized by the Neurosurgery Department, Faculty of Medicine, Universitas Airlangga. In this precious opportunity, the Neurosurgery Department, Faculty of Medicine, Universitas Airlangga has proudly invited Professor P. Sarat Chandra, MD, from the Department of Neurosurgery, All India Institute of Medical Sciences, New Delhi, Before we start our inauguration ceremony, may I bring the rundown today. First, opening, continued by National Anthem Indonesia Raya and Hymne Airlangga. Curriculum vitae reading, opening speech by the head of Neurosurgery Department, welcome speech by the Dean of Faculty of Medicine Universitas Airlangga, scientific oration by Professor P. Sarat Chandra, MD, speech by the Rector of Universitas Airlangga, inauguration ceremony, expert lecture, and last, closing. Thank you for your attention. Ladies and gentlemen, shall we start our inauguration ceremony now? As our love and proudness to our homeland Indonesia and alma mater Universitas Airlangga, we will listen to the national anthem Indonesia Raya and Hymne Airlangga. Thank you. The next agenda is Curriculum Vitae reading by the Chief of International Unit Faculty of Medicine Universitas Airlangga. Dear Dr. Asra Al-Fauzi, MD, PhD, the time is yours.
Thank you, Dr. Chacha, for the amazing opening. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Dean of Medical Faculty, Professor Poodipedi Santoso, Vice Rector of Universitas Airlangga, Dr. Miftahul Surur, the Director of Soetomo General Academic Hospital, Dr. Joni Wayuhadi, the Honorable also the Director of Universitas Airlangga Hospital, Professor Nasruddin, and Chairman of Neurosurgical Department, Dr. Arifin, and of course the Honorable, our mentor, my friend, Professor Sarat Chandra, also all the distinguished guests, ladies and gentlemen, and all faculty. Again, good morning, salam sejahtera. I will start this wonderful forum by reading out a short CV of Professor Sarat Chandra. Professor Sarat Chandra is now currently a senior professor in Department of Neurosurgery at the reputed All India Institute of Medical Science, AIIMS, New Delhi, until now for I think about 22 years. As shown in the slide, he has also held many important positions in various institutions. He was the president-elect of Indian Epilepsy Surgery, president of Skull-Based Society of India, editor Neurology of India, and other important positions in medical societies. Professor Sarat Chandra has graduated his MBBS with honors and distinction in physiology and surgery, and was the best outgoing student of his batch that time. He completed his neurosurgical training from National Institute of Mental Health and Neurosciences in Bangalore, India. And then he joined AIIMS as a faculty in 1998. And since 2011, he served as a full professor of neurosurgery in AIIMS, New Delhi until now. With his various contributions and dedication so far, Professor Sarat Chandra has received several prestigious awards, including Kadokaro Award in 2006, Sun Pharma Award in 2019 for Best Clinical Researcher in India, AIIMS Excellent Award in 2018, and visiting professor in International Neuroscience Institute, Hanover, Germany, and many more. Professor Sarat Chandra offer his experience course of 22 years. He has operated over more than 25,000 cases and also 2,000 epilepsy surgery and published 462 papers. He was also awarded for 14 extramural major risk grants and 9 patents. He published many original articles in many high-impact journals, and mostly about his interest in basic science and treatment of epilepsy. You can see here some of the journals. He has trained over 35 residents and PhDs, also 9 fellows in epilepsy and epilepsy surgery from several parts of India and other countries, such as Indonesia, Nepal, and Kenya. All fellows have successfully established their own epilepsy surgery program in their respective countries. In Surabaya, Indonesia, especially from Universitas Airlangga, we have a neurologist, neuroradiologist, the nurse, and of course, neurosurgeon, Dr. Heri Subianto, as one of his fellows. He established the Center of Excellence for Epilepsy and MEG Resource Facility, the first of its kind of facility in India, with Advanced Epilepsy Surgery Center, Advanced Brain Mapping and Electrophysiological Center, and Advanced Molecular Intracellular Electrophysiology. The center has its own research faculty, PhD students, technicians, and fellows for seamless integration of clinical research work to study causes of drug-resistant epilepsy. Till date, more than 10 PhDs passed out in a full-time research careers in epilepsy. His center helps in raising awareness toward epilepsy research in India. Professor Sarat Chandra is also the lead principal investigation for a prestigious project, Advances Research for Epilepsy, a multi-institutional first of its kind project funded by the Officer of Principal Scientific Advisor to Government of India. Some of the projects are still in progress at this time in India. As I said at the beginning, that Professor Sarat Chandra has 9 patents, including 1 patent with USA and Paris Convention Treaty International Patent. He has developed new surgical techniques for the first time, which have been validated and published in the world. These include endoscopic hemispherotomy for epilepsy, a minimal invasive procedure, and robotic thermocoagulative hemispherotomy, a bloodless surgery, and so on. Despite innovation in surgical techniques, Professor Sarat Chandra also invented some instruments and medical implants, such as EpiSafe, epilepsy synchronized automated video AG system, Dr. Chandra Disser spacer instrument from Medtronic, and Easy Track instrument for hypophyseal surgery. His key areas of research include study of various biomarker receptor in abnormal epileptogenic area, such as histone deacetylases alteration, altered kynurenine pathway metabolism, mTOR pathway in VCDs, and also GABA receptor mediated epileptogenicity, and many more. Due to time constraint, it is impossible for me to discuss all the achievements that have been obtained by Professor Sarat Chandra all this time. But at least with these few slides, we have gotten to know him. We also know how much dedication he has for the world of medicine, spatial neurosurgery, which has able to bring us to this point. Thank you for your attention, and thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Asra Al-Fauzi, MD, PhD. Ladies and gentlemen, the next agenda is the opening speech by the head of Neurosurgery Department, Faculty of Medicine, Universitas Airlangga, Dr. Soetomo General Academic Hospital. Dear Dr. Muhammad Arifin Parendrengi, MD, PhD, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah, praise to Allah for giving us opportunity catering this event. Vice Rector Universitas Airlangga, Dean of Faculty of Medicine, faculty, students, alumni, and staff. As head of Neurosurgery Department, I bring you warm greetings and welcome to Adjunct Professor Inauguration Prof. Sarat Chandra. On behalf of all staff of Neurosurgery Department, I'm here to offer a very hearty welcome you, Prof. Sarat. We especially appreciate your focus in the field of epilepsy and epilepsy surgery and your innovation in neurosurgery field and your continuing contribution for us in Surabaya to build a tertiary epilepsy center in Indonesia. We have been working together since August 2013 during functional neurosurgery course. It was the cornerstone of collaboration, continued by a course at 2016, and delegate our staff, Dr. Heri Subianto, neurosurgeon in the epilepsy surgery fellowship program, Dr. Nemi Novitasari, neurologist with a nurse to learn on electroencephalography monitoring, Dr. Vidiana Feriastuti, neuroradiologist, for a fellowship on epilepsy imaging. And the last, Dr. Ersifa Fatima, neurologist, with a nurse to increase understanding of epilepsy. Now it's time for us to work as a collaborative team in the field of epilepsy. I hope that today inspires ideas, discussions, research, and more collaborative events to better life. Prof. Sarat, congratulations on your inauguration as a young professor of Medical Faculty of Universitas Airlangga, and we look forward to even better collaborative in the years to come. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Muhammad Arifin Parengrengi, MD, PhD. The next agenda is the welcome speech by the Dean of Faculty of Medicine, Universitas Airlangga, dear Professor Budi Santoso, MD, PhD. The time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. First of all, I would like to express my sincere gratitude and hearty welcome to the Vice Rector of Universitas Airlangga, Dr. Miftahul Surur, PhD, all Vice Dean of Faculty of Medicine, Universitas Airlangga, Dean Staff Coordinator, Faculty of Ambassador Officer and Team, Head of the Neurosurgery Department, General Hospital, Dr. Soetomo, all honorable participants joining this. Distinguished guests, respected colleagues, ladies and gentlemen, thank you all you for taking time out of your busy schedule to join us here today. We gather here to celebrate Professor Sarat Chandra exemplary accomplishment over a long and distinguished career as a leading medical scientist, educator, also an innovator. Professor Sarat Chandra has earned abiding respect from his colleagues, and wide international acclaim for his outstanding work, especially in the field of epilepsy and minimally invasive surgery. The achievement of Professor Sarat, who has become the professor as well as the principal investigator in his institution, certainly has a lot of experience that we can make as an example. He is certainly very well trained in dealing with various problems related to the development of innovation and education, especially at All India Institute of Medical Science, AIIMS, New Delhi, India. This valuable experience will be delivered and shared by him to all of us through this morning scientific oration and also expert lecture session. I believe this meeting will help further shape our understanding of the importance of innovation in education and medicine, especially neurosurgery. It will also give us a chance to reflect more deeply and think more objective about how innovation in our education system worked so far and how to develop it. We certainly hope that after Professor Sarat's inauguration as one of our honorary professor, he can transmit his success story and experience in AIIMS to our beloved institution, Universitas Airlangga. Because we believe that comparative and international based research and education program will position us as a center of excellence in creating knowledge while facing global competition. Professor Sarat Chandra is presently honorary professor of Universitas Airlangga. We here at Universitas Airlangga remember Professor Sarat for his vital contribution in rebuilding the collaboration of our College of Medicine, especially in neurosurgery field. But his connection with our university does not end there. In this capacity, his vision and leadership made possible extensive neurosurgeon exchange between our two universities. A neurosurgeon who will also be the moderator of today's scientific forum, Dr. Heri Subianto, has been sent to the Department of Neurosurgery, All India Institute of Medical Science, AIIMS, New Delhi, India, for further education, advanced training, and valuable fellowship. Right now, Professor Sarat Chandra, in turn, came virtually fulfill the invitation from Universitas Airlangga to be an honorary professor. I could actually go on listing the countless accomplishments associated with Professor Sarat Chandra name, but I will simply say that as Dean of Faculty of Medicine, Universitas Airlangga, it gives me great pleasure to present the honorary professor degree to Professor Sarat for his lifetime caring and contribution to the development of this university. I know of all my faculty colleagues, present and past, join me in expressing our gratitude to you in the modest but heartfelt manner. Thank you, Professor Sarat Chandra. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Budi Santoso, MD, PhD. Ladies and gentlemen, the next agenda is the scientific oration by Professor P. Sarat Chandra, MD, titled Finding New Cheese in Neurosurgery. Dear Professor P. Sarat Chandra, MD, you may begin your oration.
Is my screen visible and am I audible?
Yes, Professor.
So thank you so much. I'm indeed deeply honored, moved, and touched by this warm gesture from University of Airlangga and all the faculty, residents, and staff. I was truly touched by the introduction given by my dear colleague and friend, Professor Asra Al-Fawzi. And it's very warm-rending to see that your teachers and your founders are still actively associated with you in the likes of Professor Abdul Majal. Honorable Dean of the University, Honorable Director of the University, esteemed faculty, dear residents, and all the other people who are sitting here, I would like to express my immense sense of gratitude for having given me this opportunity to make my presentation. So as you see, the topic is slightly unusual. And I thought I should speak upon an unusual topic to understand whether we can create some kind of innovations in our daily busy clinical lives. So this oration is actually a story. I do not know how many of you have read this book, Who Moved My Cheese? If you are not, I will strongly recommend all of you to read this book. So the book is about 4 persons, which includes 2 mice, 2 little people in cheese station C. It's a hypothetical cheese station. Now, every day they would come by 9 a.m., they would eat their cheese, they would gossip, do their work, have their lunch, and go back to homes by about 5 p.m. And soon they started thinking that the cheese will last forever. And each of these 4 people had different personalities. So we have first him, who was one of the little people who didn't want to change. He always would say that it's not fair, I don't want to change, I want to stick to old traditional established methods. How? Who's startled by the change. So whenever change happens, he's taken aback for some time. But then he accommodates and adapts himself in order to be a part of change, and then later on becomes one of the prime movers for the change. In contrast, the 2 mice, Snip and Scurry, they are completely different. They can smell the change in air and they immediately go into action whenever there is a change happening. So one day, the cheese runs out in the cheese station. So there is no more cheese left. So what do? Snip and Scurry immediately moved out to search for new cheese. How was afraid, he stayed for some time. He would come every day along with him to see if the cheese has come back, and then finally decides that he indeed has to venture out and make a journey to find new cheese. Hem stays back. He says, I'm not going to go anywhere. The cheese was here, it's going to come back one day, and every day he would go there, find no cheese, come back, grumble, and become frustrated. This particular oration is a journey of Haw through the maze till he finds new cheese. And in that way, I think I identify myself with this journey. So my tryst with innovation started almost 20 years ago when I had an idea of developing an endoscopic carpal tunnel syndrome, carpal tunnel set for carpal tunnel surgery. It was a low-cost disposable device. I did it in more than 200 patients. So all you require is you have this disposable instruments and you just require 2 sutures. It was a bedside procedure. It was around 1,000 rupees, which I would say is around approximately $15 to $20. And then he would go home, the patient would go back the same day. And we did publish a paper. And finally, after 10 years, we did do commercialization. It was very difficult to get it patented, to learn all the nuances of how to go into the intellectual property rights and how to get it commercialized. And by the time it came out, there was not much interest because there were similar products in the market. But this experience has left me with very, very important learning points. I learned that intellectual property rights is as tangible as a real property. Time is of essence whenever you develop an idea, and you have to enjoy the process. So to quote what Bill Gates has said, intellectual property rights has a shelf life of banana. So if you wait for too long, nobody is going to be interested in what you have innovated. So what happens to Howe now? He came to some bits of cheese in another cheese station called Cheese Station E, and he wished that he could have come there earlier. He ate those crumbs of cheese which was lying there, and he felt very happy and very important. And he learned two important things we wrote down on the wall of that cheese station. The quicker he let go of the old cheese, the sooner he would find the new cheese. And he also realized that when you have new cheese, it makes you happy. So I further moved on, and that's where I had already operated close to 800 or 900 craniovertebral junctions, because that is what I was doing right from the time I became faculty in 1998. And then I was always intrigued by the fact that transoral is never required. And doing a transoral excision with posterior fixation is an old cheese. And that's when I started. Of course, I was influenced by Professor Atul Goyal's work, and this is my experience. And then we developed a new technique called distraction, compression, extension, and reduction, and also published several papers. And again, there's a few more papers in neurosurgery. And then recently we published a new hypothesis for CV junction based on genetic studies. And then this is an editorial for the video section on craniovertebral junction anomalies in neurosurgical focus. So fundamentally here we put a spacer and we apply compressive forces between OC1 and C2 so as to reduce the AD and BI completely. And this is few more papers. This is a deformity correcting surgery. So that is why when we do this, there is a complete spinal correction of the entire curvature. And that is why it is a physiological process. For very complex anomalies, we went ahead to describe a technique called as extra-articular distraction, because these have something called as pseudo joints. And we developed techniques whereby you could put spacers in the pseudo joint and completely reduce such severe anomalies and relieve the patient just through a single stage posterior approach. And then we developed implants which would have spacers attached to these connectors. Now I've realized quite early ahead that in severe bacillar invagination, for instance, you can see here it's up to the base of C2. Not only would you require the dents to come down, but you would require a pushing force at the level of C2 in order to oppose the C2 with the clivus. And that is where I started working with Medtronic. We signed an agreement through the research section of All India Institute of Medical Sciences. They were quite excited with this idea. And this is my US patent. And this is what we developed. It's a universal reducer. So you put a spacers, and then you can just turn and pull the wire and the whole anomaly gets reduced. It cuts down your surgical time. The whole anomaly can get reduced just in 15 to 20 minutes. So this is how we apply the reducers. So this is a case without the application of universal reducer. And this is a case with the application of universal reducer. And you can see there's a beautiful reduction with this device. So the new cheese, what I found for craniovertebral junction with more than 1,000 cases of my experience and 300 only with posterior technique, is to intraoperatively manipulate, reduce the anomaly, and then correct the deformity. And in my case, using a universal craniovertebral junction anomaly. So what happened to Howe? So he wondered whether he could go back to cheese station C or go in a new direction. And finally, he decided to go in a new direction. And he wrote this on the wall. Movement in a new direction helps you to find new cheese. So that's when, we had already an experience of almost 500, 600 cases of epilepsy surgery. And that's when I came across the idea of developing a minimally invasive technique. And we developed the endoscopic hemispherotomy. And this was almost considered impossible because people would say, how can you disconnect an hemisphere through a small opening? But that is what we did. And you can see in several papers, we have Harry's name, and Harry now is an expert in endoscopic hemispherotomy, where just through an opening of 3 into 2 centimeters, you could perform a complete hemispheric disconnection. We also described for the first time an endoscopic assisted corpus callosotomy with a pan-commissurotomy for a serious syndrome like Lennox-Gastaut syndrome. So just to show the impact of these techniques on public, on patients. So this was a young lady who came all the way from Yemen, which was war-torn. She lost her husband. Her child was having several hundred seizures per day. So she went to pillar to post. Finally, she came and contacted us, and we did an endoscopic corpus callosotomy with commissurotomy, and his seizures completely stopped. And she was able to take back this child back home. And this came out in the media. So both the techniques are now part and parcel of standard textbooks. And you can see here again in this very nice textbook, which is a foreword by Professor Yasargil, who is a neurosurgeon of Millennium. We have Heri Subianto's name in both the chapters. And then we published this landmark article in the New England Journal of Medicine, which has more than 200 citations, which is the first of its kind of study, a randomized controlled trial for drug-resistant epilepsy in children. And this study showed that children who undergo surgery have a 10-fold chance of becoming seizure freedom as compared to those who only undergo medical treatment. And in addition, it leads to optimal preservation of cognition. So the sooner you operate the children, the better will be their cognitive outcomes. So these are the new cheese which we developed: endoscopic hemispherotomy, corpus callosotomy, and they formed hope for children with unihemispheric or bihemispheric pathologies. And most recently, we came out with the technique of a bloodless method of doing a hemispheric disconnection, whereby we introduce electrodes using a robot and do a radio frequency ablative disconnection. For me, this was a dream, because I started from an era where we had to physically remove the hemisphere in order to do the same procedure. So starting from a hole in the brain to this bloodless technique of hemispheric disconnection was indeed a change of paradigm, which was very, very significant for us. We also developed the technique of ROSA-guided hypothalamic hematoma, and I thank my colleague, Dr. Ramesh, for having actively worked with this. And again, you can see Heri Subianto's paper, name in this paper. So what happened to How? How was afraid to explore new corridors, but he overcame his fear and plunged. And there was enough cheese bits in the corridor which kept him going. He realized something at this point of time and wrote it on the wall. He said, it's safer to search in the maze than to remain in the cheeseless situation. And old beliefs do not lead you to new cheese. And we went ahead and we developed a new retractor for endoscopic surgery. The reason why I developed is I have been doing endoscopic pituitary surgeries almost, I think, for 15 years or 10 years. And I always felt all this, most of this equipment was unnecessary. It's more of a marketing gimmick. And pituitary tumors form 80% of endoscopic surgery. And I hate this binostril technique because you're introducing scopes through both the noses, you're destroying the mucosa. And this is a pristine surface. We do not have any right to destroy this pristine surface. And the complications should not be underestimated. You can see the severe degree of optic atrophy in a patient who underwent an endoscopic endoscopic pituitary surgery in a place elsewhere and came for us for a redo surgery. So this is a retractor which again we developed. We spoke to somebody and along with our Center for Research. And this is, we got it patented. And this is how it works. It's dynamic, flexible, minimizes use of standard endoscope instruments. You can actually use your usual instruments, maximizes space and easy retraction. It's made with special alloy coated with non-stick Teflon, and it's fibrin coated to reduce the bleeding. So just to show you a short video. So we approach the pituitary through a transseptal approach, and we create a very nice submucosal flap. So that way we are not, and this is a area which most of the neurosurgeons are accustomed to. We know this anatomy too well. And then once we develop the submucosal tunnel, we introduce a retractor inside. The retractor slips in easily because it's very thin. And once we introduce it, we pull out the ring in order to deploy the retractor. So the moment you pull out the ring, the both flanges of the retractor open up. And then using suction, we further open the flanges of the retractor. And then using endoscope and suction, we put pressure on the base of the retractor so as to create a septal fracture to one side. And then following this, you have all the standard anatomy, which you are very much used to, and you can go ahead and remove the pituitary tumor in the most standard fashion. Your visualization is excellent. You have a lot of space. You can in fact put in 4 instruments while doing the surgery, which is not possible in the traditional endoscopic approach. And once the surgery is over, we pull back the retractor and we apply 1 stitch over the mucosal flap, and you can see the entire pristine surface of the nasal cavity is preserved bilaterally. And this definitely translates into a more superior nasal quality of life. So we started with pituitaries and then went on to this giant craniopharyngiomas which had to be staged. And we also do extended skull base approaches. So it's flexible, it's expandable, it's uninostril, it's dynamic, it's spacious, it's truly minimally invasive. It's easy, effective, and elegant. Proceeding on, we also described a very, very effective and an inexpensive technique to treat a very horrible pathology like vertebral hemangiomas causing compression. So if you try to do surgeries, you can end up losing 3 liters or 4 liters, or even the patient could die on table. But then we introduced the concept of intraoperative open injection of absolute alcohol, which costs less than $2. And on long-term studies, we have shown with more than 10 years now, we have shown that there is not only complete regression of the vertebral hemangioma, but there is also formation of bone sclerosis, new bone formation, which stabilizes the vertebral body. And these are the papers which we published in this direction. So now what happens to Howe? He comes to his darkest corner yet. He felt afraid, yet when he took the plunge, he felt good. He realized something and wrote it on the wall. When you stop being afraid, you feel good. So this was my darkest corner, whether we would be able to establish a basic sciences lab, because having a clinical background, that is something which I would always feel worried about. But then with a lot of hard work and support from all my team members, we were able to establish this Center of Excellence for Epilepsy, which has a neurobiology lab where we do targeted sampling. And just to show some papers which we have published, and Professor Fauzi has already described about this. And this is one of our recent papers published on our experience with MEG. And we also described a new biomarker, kynurenic acid, potentially for treatment of epilepsy, and we have got it patented. And these are some of our achievements, and these are the people who are associated with it. And then finally, at this time, we're in the process of developing a portable video EEG system, which would have an AI-generated algorithm instead of EEG, and we are in the process of developing it. So this patient had seizures arising. Most of the semiology was from the frontal lobe seizures, but when we did the AI algorithm, we found that even though the seizures would arise from the temporal lobe, there is a burst of activity into the frontal lobe, and then it would settle down somewhere in the insular area. And when our neurologists re-looked into the video EEG, and indeed they found that there was an origin from the temporal lobe, and it was spreading to the frontal and then to insula. So what happened finally? So Howe finally came to Chi Station N. So his journey started from Chi Station C till N, and he found sniff and scurry, and he found plenty of new cheese. And he was confident that all this clues which he has left would allow him to come and find them one day. And what happens to him? The book is open-ended. It's the choice of him. He could have perhaps followed Howe's over a period of time and would have joined them in Chi Station N. So what was the story all about? Cheese stands for a metaphor of change. It's a metaphor for what we want in life, whether it's a job, relationship, money, big house, freedom, health, recognition, spiritual peace, or even an activity like basketball or running. Each of us have our own idea on what cheese is, and we pursue it because we believe that it makes us happy. If we get it, we become attached to it, usually. And if we lose it or taken away, it could be traumatic. Maze represents where we spend majority of our time looking for what we want. It may be the organization you work, the relationships you have in life, or the community you live in. Sometimes the corridors and chambers contains delicious cheese. They also have dark corners and blind alleys, and you feel as if you're completely lost. And then there is a possibility that you could always get out. So our new cheese in this journey has been starting with a disposable endoscopic carpal tunnel set, proceeding on to the universal CV junction reducer, to description of new minimally invasive techniques for epilepsy, development of a new retractor for endoscopic pituitary, development of a very, very easy technique. Now, this technique of alcohol injection is now done by every surgeon in the country. It's very easy and leads to complete embolization, along with single stage fixation for vertebral hemangiomas. Then areas of translational research for better understanding of epileptogenesis in 3 areas, and 1 possible molecule for epileptogenesis. So cheese is all about change. So let us replace cheese with change here, and let us see what it comes to, how it reads like. Smell the change often so that you know when it is getting old. Adapt to change quickly. The quicker you let go of the old things, the sooner you can enjoy the new change. And finally, last but not the least, I think this is what inspired me most. What would you do if you weren't afraid? So if you want to devise a new technique, think of the most wackiest, craziest, impossible thing. For me, 10 years ago, I thought, could I ever develop a bloodless hemispherotomy, which sounded like an impossibility at that point of time, because the surgical standard was to do a large craniotomy and physically remove the entire hemisphere. But today, we were able to achieve it. We developed the technique of Roche, which doesn't even lose 1 ml of blood. We wrote it in the paper, 5 ml for the sake of modesty, but if you see the procedure, Harry completely understands that we do not even lose 1 cc of blood. So change happens, we have to be aware of it, and we need to adapt accordingly. So terima kasih, and thank you so much for this honor once again. It's been my greatest pleasure to give me this talk,
Thank you, Professor P. Sarat Chandra, MD, for the knowledge that has been given to us. Ladies and gentlemen, the next agenda is the speech by the Rector of Universitas Airlangga, represented by the Vice Rector of Universitas Airlangga for Internationalization, Digitalization, and Information. Dear Dr. Muhammad Miftahul Surur, MD, PhD, you may begin your speech.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Most cordial greetings from Universitas Airlangga, Indonesia. The Honorable Dean of Faculty of Medicine, Universitas Airlangga, the Honorable Head of Department of Neurosurgery of Faculty of Medicine, Universitas Airlangga, and of course, our esteemed adjunct professor candidate, Professor Poodipedi Sarat Chandra, MD, from All India Institute of Medical Science, New Delhi, India, and all the distinguished guests and faculty members. I sincerely thank you for taking your time to be with us today on the inauguration of Professor Poodipedi Sarat Chandra, MD, from All India Institute of Medical Science, New Delhi, India, as adjunct professor at the Faculty of Medicine, Universitas Airlangga. Since I have lived in India to learn at the Asian Institute of Gastroenterology, Hyderabad, for 3 months, thus I know well about the reputations of All India Institute of Medical Science as the best university in India, as well as reputation of Professor Sarat Chandra. It is such an honor for me personally to be able to witness the milestone of a distinguished fellow academic. And as academic, we have duties to better our contribution to the society as well as exploring the limitless opportunities for the brighter future of education. And we pledge to always dedicate of our achievements for the sole purpose of fulfilling these duties. And I know that I can rely on Professor Poodipedi Sarat Chandra to be able to play his part of upholding this pledge. And some of you have probably heard all this before, but what I am about to tell is true nonetheless, that Universitas Airlangga regards our adjunct professor in high esteem. As our university's partner, adjunct professor play significant roles in our relentless endeavor to constantly strive for the university's overall academic performance enhancements. Proposed academic collaborations, not to mention the potential collaborative research, are the very strands woven into the elaborate cobwebs of our expanding network. So hence, we are forever grateful for the adjunct professor and unwavering support, and that our university is able to maintain our steadily rising global reputations. On behalf of academic from Universitas Airlangga, I would like to once again thanks and congratulates to Professor Poodipedi Sarat Chandra for his remarkable achievements. Having acknowledged this, it is unfortunate indeed that I cannot congratulate Professor Poodipedi Sarat Chandra in person. Neither can I be with you all in person to celebrate today milestones as we normally would have. However, please know that my thoughts and well wishes will always be with you, and I'm holding on to hope that we will eventually be able to see each other face to face by next year. Here's to a new beginning and more windows of opportunities for Professor Poodipedi Sarat Chandra. May blessings be bestowed upon you always. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Muhammad Miftahus Surur, MD, PhD. Ladies and gentlemen, now we reach the main event of today's agenda, the inauguration ceremony, honorary referring as the adjunct professor to Professor P. Sarat Chandra, MD. We invite the representative of the Rector of Universitas Airlangga, our Vice Rector of Universitas Airlangga for Internationalization, Digitalization, and Information to grant the Award of Honor to Professor Poodipedi Sarat Chandra, MD. To our Vice Rector of Universitas Airlangga, please hand symbolically the placard and certificate of honor to Professor P. Sarat Chandra, MD, as the Adjunct Professor of Universitas Airlangga.
Thank you very much. On behalf of Universitas Airlangga, and in particular of the Faculty of Medicine, Universitas Airlangga, I handed the certificate and plaque as your acknowledgement as the adjunct professor of Neurosurgery Department of Faculty of Medicine, Universitas Airlangga. Congratulations to Professor Poodipedi and also Department of Neurosurgery, Faculty of Medicine, Universitas Airlangga. Congratulations.
Thank you very much. I'm deeply honored. Thank you.
Thank you, Dr. Muhammad Miftahus Surur, MD, PhD. Thank you, and congratulations to Professor P. Sarat Chandra, MD. Ladies and gentlemen, that was the end of the inauguration ceremony. Dear Vice Rector, Dean, Vice Dean, and distinguished guests may leave the Zoom meeting. The next agenda is the expert lecture by Professor P. Sarat Chandra, MD, with Dr. Heri Subianto, MD, as the moderator.
1983 saya kembali dari Belanda, kemudian kami bekerja berempat, Profesor Basuki, Dr. Muhammad Saidar Madipura, Dr. Umar Kasan, dan saya sendiri. Lalu kami mulai bekerja tahun 84, dibentuklah grup bedah saraf. Itulah asal mula kelahirannya. Jadi kalau grup bedah saraf itu di mana-mana ada. Dokter bedah saraf yang ahli pun banyak. Kami punya satu kekuatan di sini bahwa grup ini berpijak dari universitas. Universitas itu landasannya adalah riset. Oleh karena itu kita namakan Institute. Neuroscience, ada science di situ. Ilmu yang mempelajari secara mendalam tentang sistem saraf, baik itu penyakitnya maupun teknik menanganinya. Itu yang menjadi kunci daripada SNE ini, bahwa kita didasari oleh perilaku akademik. Kita dapat memberikan yang terbaik kepada masyarakat dalam bidang bedah saraf. Jadi SNE itu sebetulnya adalah kristalisasi dari pemikiran para ahli tadi yang ada, karena masing-masing anggota SNE itu punya kelebihan sendiri-sendiri.
Setiap anak punya kesempatan dan punya harapan untuk jadi lebih baik. SNE punya satu divisi pediatrik yang dapat menolong anak-anak Indonesia untuk meningkatkan kualitas hidupnya, mendapatkan pendidikan, menjadi anak-anak yang berkualitas, dan menjadi mereka generasi penerus yang kelak akan menjadi pengganti-pengganti kita dengan kualitas yang terbaik.
Kalau SNE bisa menggalang Lions Club, Lions model-model yang nasional, apalagi kalau pemerintah pusat bisa didorong untuk mendirikan Pediatric Brain Foundation, itu anak-anak dengan kelainan otak yang sifatnya kongenital akan sangat tertolong.
Jadi tulang belakang itu dia adalah struktur yang melindungi sumsum dan saraf yang luar. Jadi dia sebagai support, sebagai penahan supaya tidak terjadi cedera pada sumsum maupun saraf.
Pengalaman yang paling berkesan, yang menyenangkan itu adalah apabila kita bisa memberikan sesuatu kegunaan pada pasien tentunya, dan melihat pasien itu tersenyum, itu kita akan sangat merasa gembira di situ.
Saya akan sangat senang, dan itu merupakan cita-cita saya, bisa memberikan pelayanan sesuai dengan kebutuhan pasien, sehingga pasien bisa terbebas dari rasa sakitnya, dari penyakitnya. Itulah. Karena itulah kita menghimpun diri dalam Surabaya Neurosurgeon Institute. Tujuannya adalah agar kita bisa memberikan layanan pada pasien itu sesuai dengan standar internasional, memanfaatkan teknologi modern yang sesuai dengan peruntukannya, kemudian juga sistem pelayanan yang terstruktur dan terstandar yang diakui oleh dunia internasional.
Setiap pasien adalah istimewa. Setiap pasien adalah makhluk-makhluk istimewa yang kita diberi kesempatan oleh Tuhan untuk membantu mereka.
Pasien di mana dalam kondisi koma karena ada perdarahan di otak, karena ada aneurisma yang pecah sehingga kesadarannya menurun sekali, kemudian datang ke kita, dan kita otomatis kita anjurkan untuk dilakukan suatu tindakan. Karena usianya sudah tua, maka pilihan yang paling baik pada pasien tersebut adalah kateterisasi otak atau endovaskuler. Ya. Jadi kita bisa lakukan tindakan dengan minimal invasif tanpa operasi.
Pasien stroke itu menyebabkan angka kecacatan dan kematian paling tinggi.
Kemajuan teknologi di bidang saraf adalah ditemukannya stereotaktis.
Dengan adanya teknik yang baru ini, dengan stereotaktik neurosurgery ini, kita berharap ini merupakan menjadi harapan yang sangat baru untuk pasien, sehingga pasien bisa meningkat kualitas hidupnya.
Pasien kecelakaan lalu lintas datang ke UGD dengan kesadaran yang sangat rendah sekali. Itu saya harus segera menangani mereka dengan cepat, bahkan dengan bantuan dokter-dokter yang lain. Dengan RW breathing circulation itu juga harus dilakukan secepat mungkin tanpa adanya kesalahan sedikit pun.
Ada hubungan yang sangat erat antara pendidikan dengan pelayanan.
Dengan teknik-teknik operasi yang baru, metode pengobatan yang baru yang kita jalankan, insya Allah akan memberikan manfaat lebih bagi pasien.
Harapan selalu ada buat kita. karena kita mengedepankan kejujuran.
Ladies and gentlemen, the next agenda is the expert lecture by Professor P. Sarat Chandra, MD, with Dr. Heri Subianto, MD, as the moderator. Dear Dr. Heri Subianto, MD, the time is yours.
Thank you very much, Dr. Sasha. Good morning, everyone. My senior, Professor Abdul Hafid Bajamal, and Dr. Asra, Vice Rector, Universitas Airlangga, Dr. Miftahul Surur, and all colleagues, all staff, all residents of Neurosurgery Department, and also our distinguished guest, Adjunct Professor, Professor Poodipedi Sarat Chandra, who is my mentor. I know him lots, not only it's about epilepsy surgery, but also how we deal with our life also. Okay, now we are moving to expert lecture by Professor Poodipedi Sarat Chandra. As we know that epilepsy, it is a collaborative project. We cannot perform epilepsy by ourselves, by our department, but we have to make a good collaboration, usually with Department of Neurology, Department of Neuroradiology, Department of Pediatric. Good morning, Prof.
Yes, good morning, Harry. Let me share my screen.
Yeah, now it's time for Professor Sarat Chandra to deliver expert lecture with the title Creating Innovative and Cost-Effective Measure for Epilepsy Surgery. Prof, time is yours.
Thank you so much, Harry. Am I audible completely and visible?
Yeah, it's good, Prof.
So thank you so much, Harry, for that introduction. And you know, you are very dear to me. It was a pleasure to have you as a fellow here. And it's indeed very heartwarming to see your success in Surabaya. We will soon hope great things from you. And we hope that your center at Surabaya would be the topmost tertiary center in Indonesia. And at the outset, again, I would like to express my sense of gratitude to Professor Abdul Hafid and Professor Asra Fauzi and the entire Dean and Director of the Institute and the entire faculty, staff and residents. So today I would be speaking on a topic which is very relevant for a country like India and Indonesia. We have a huge developing population. We have a heterogeneous population. We have some people who are very rich, and we also have extreme poverty. So that's why we are called as developing world. But this is where the entire action is. And this is the place where we have a maximum need to develop a program for epilepsy surgery. And if you look at the statistics, 60 million people suffer from epilepsy worldwide, and 80% of them live in resource-poor countries. Incidence of epilepsy in low-income countries is as high as 190 to even 200 per 100,000. About 40 million people with epilepsy in developing countries do not receive appropriate treatment. Now, solutions are not easy, but every climb starts with the first step. And this is a very old Turkish saying. And this you can see is the Mount Everest. So if we have to scale the Mount Everest, we first need to reach to the base station, and then we have to train, and then we go to the next step. So that is how development of epilepsy surgery is. It doesn't happen in one day. It takes some time, it takes some years to establish, because it's not just the surgery that we need to do, but it's also the entire team that has to be created. It's the synergy that has to be created. It is a collaboration which you have to create between various departments. Now, if you look for barriers in developing countries like India, so there is definitely a treatment gap and delay in referral. There are lack of diagnostic resources. There is trend towards complex paradigms in countries with resources. So when you listen to lectures from Cleveland Clinic or from other advanced institutes in Europe or US, their approach to epilepsy is very, very different, which is not financially viable for our countries, and inability to sustain programs and manpower training. So let's look at this. Let us look at this step by step. So when we started our program in 1995, there was no structured program anywhere in the country. There was a very low level of awareness. In general public and even neurology and neurosurgical fraternity. Many were not interested to pursue this career option. And neurologists most often did not have any idea of epilepsy surgery. They used to think that epilepsy surgery is something which you need to do when patient is about to die because of epilepsy, or it's some kind of fascination. It doesn't actually exist. So that was the situation in 1995. And this is our situation today, where epilepsy surgery is very widely accepted. We have several young people who are interested to take up a career in epilepsy surgery, and we are getting more and more patients. In fact, at AIIMS, we now have a waiting list for almost 2 years. And we were able to develop the Center of Excellence for Epilepsy, which allows a seamless integration not only across departments, but also across various specialties, including clinical and basic sciences. Now, before I proceed, I would like to explain to you what exactly is an epileptogenic network. So nowadays, we do not call it as epileptogenic focus or epileptogenic zone. We prefer to call these as epileptogenic networks. So this is a video, and if most of you can guess, it's actually the flight pattern which is shown here of various flights which are going from one place to another. And when we see this, we notice something very, very distinctively. We find that there are certain hubs. For instance, you have a large hub in Dubai, you have a large hub in London, and over here you have two major hubs, which is Delhi and Mumbai. And again in US, you have similarly large hubs. So when you need to go from one place to another, you cannot directly fly to that place. You first need to go to a large hub, and then from there maybe take a connecting flight and then go to a smaller place. That is a similar situation for epilepsy in the brain. So in brain also we have various hubs or nodes, and there is reason to believe that this kind of structure exists, because if the brain were to be randomly connected, it would take up almost 50% of the body's metabolism, and we know that the organization in the brain is very, very intelligent. So this is how the brain saves its energy, by creating hubs. So the impulses first grow to the hubs and then they go to other places. So if you look at the concept of zone versus network, in zone we typically picturize the lesion in the center and zone around, whereas in network we could have a lesion away from the zone connected through a networks. And unlike zone, the networks are dynamic, multiple, expanding, which means that if you see a patient today with an epileptogenic focus, and you follow up this patient after 10 years, it would be the outcomes would be much different to operate this patient after 10 years, because the networks would have become much more complex and much more widespread. And that is one of the compelling reasons why we need to do epilepsy surgery as early as possible. Similarly, networks could be multiple. So they could be distributed all over there could be 2 areas or sometimes even 3 areas. And if you do not do anything, they will continue expanding, and sometimes the whole brain may be involved. And if you look at the mechanism of recruitment, you have local neurons which stimulate the distant neurons, which again come back to the local neurons, and more distant neurons are recruited. So networks are dynamic, multiple, and they keep on expanding. And we also understand that these networks do not operate through linear mechanics. They operate through non-linear dynamical systems. And one of the biggest fallacies is that our EEG and MEG analysis is based on linear mechanics. And that is the reason the kind of data we get from EEG and MEG, it's useful, but it's not a complete data. It doesn't give us a complete idea of the complexity of networks. Now, we are all aware of this landmark study by Weeb et al., which was published in 2000. This was the first randomized controlled trial showing an improvement of almost 60% versus 8% between the surgical group and medical group. This has now several citations, and we were the first to publish the first randomized controlled trial in children, which established not only a 10-fold improvement in children, but it also showed that children who underwent surgery had better cognitive outcomes. Now, when we compared early versus delayed surgery, we found that children who were operated after 1 year had lower cognitive and developmental outcomes. So in children, it's not only important to operate them. It's not only important for us to operate on kids who have drug-resistant epilepsy, but it's also important for us to do it as early as possible. We cannot delay it. Otherwise, it leads to irreversible epileptic encephalopathy. Now, let's go through each one of these points in overcoming barrier. So the first is treatment gap and delay in referral. And now it's very important for us to define the causes of drug-resistant epilepsy. Now, we published this paper some time ago. Dr. Manjari published this. And through this paper, with a cohort study of over 200 versus 200 well-controlled epilepsy, we were able to show that if you find a structural abnormality on MRI and the patient does not respond to the first anti-epileptic drugs, these are the 2 most important factors which play the most important role in the patient becoming or developing drug-resistant epilepsy. So whenever you have a structural abnormality or the patient does not respond to the first anti-epileptic drug, we should start considering that the patient would likely be having drug-resistant epilepsy. Now, this is an algorithm which we created for management of epilepsy surgery in our center. It looks complex, but let me walk you through it and then you will understand. So the step 1 is MRI. Now, it's very important that if a patient comes with an MRI from any other peripheral center, and it does not show a lesion, you read radiologist's report that there is no lesion here. It does not mean there is no lesion. You have to do an epilepsy MRI as per epilepsy protocol. And if it is negative, you again have to ponder over it. Now, in our own center, we find that the patient comes with an average of 3 MRIs done, which was negative. And when we did an epilepsy protocol MRI with 1 millimeter sections, we were able to find these subtle lesions. And this has made all the difference, because when you find the subtle lesion, patient could be having seizures for several years, several decades. And when you remove it, they will have the chance of becoming completely seizure-free. Now, in approximately 20% of the cases, we can find that when we do a more advanced investigation like PET MRI fusion, that is when we end up detecting a large area of hypometabolism. And then when we go back to the MRI, we will be able to detect subtle lesions. And we published this paper for the first time along with Professor Gary Mathen in UCLA. And right now, PET MRI is a standard investigation which we do in our epilepsy setup, because it helps us to pick up very, very subtle lesions. It's also important to sensitize your administration, your political machinery, to create a national program for epilepsy surgery so that there could be more awareness. So in this direction, Dr. Manjari got along with all the senior neurologists across the country, and they published this white paper, which is a need for a national epilepsy control program. It is still in process in the health ministry, but unfortunately it's been put off by the COVID pandemic. But when the pandemic is over, hopefully we should be able to create a national epilepsy program. And in this paper, they have described a paradigm on how the patient referral can be done from peripheral level itself to decide whether the patient has to be referred to the tertiary center or not. It's important to create parallel social development platforms. So I will encourage Harry and his team to create some kind of a social platforms. You can call all your patients who have been operated. You can organize some kind of parties for them. You can give public awareness lectures. So these go a long way in developing awareness for epilepsy surgery. And here Dr. Manjari started an organization called as Ekatvam, which in Sanskrit stands for Together Against Epilepsy. And now this is completely managed by people who have had epilepsy or who are operated by epilepsy. And they have a lot of passion to continue this forward. It's also important to create a tiered system for referral for epilepsy surgery. And in this paper of ours, we have described how we can create level 1 and level 2 centers. And it's important to create this kind of tiered system, because one has to understand that epilepsy is an umbrella term. You could have very straightforward cases. You could have very complex cases. You don't need all the investigative machinery in one place. So that could be a level 1 center. And if there is any complex problem, it could be referred to a level 2 center, which is a more advanced center. But again, it's very important that you should establish a level 2 center first. It's not that you start with level 1 center. At least in one place in the country, couple of places in the country, you should establish a level 2 center with all possible investigations. And then using that as a hub, you could develop various level 1 centers as spokes. One of the important challenges we have in developing countries is lack of diagnostic resources. So this should be overcome by optimal utilization of resources. And in that respect, accurate MRI diagnosis using optimized protocols are very important. For instance, if you do an MRI PET fusion, that could pick up very subtle lesions. Similarly, it's not too expensive for us to have an ictal SPECT. SPECT is not very expensive. Most of the hospitals already have it. And then, of course, I wouldn't advise MEG unless you get it from some kind of a government source, because it's very expensive. But definitely getting a MEG is a big asset for you. Now, all these investigations could be placed in one area. And if it is given by a funding through government, then this could be subsidized for all the patients. And most of the patients could be referred to this center for getting these investigations done. And it's very important to examine the MRI closely, re-examine the MRI once again, repeat the MRI if required, sit with the neurologist, go through the area where they think is epileptogenic seizures, and that's when you will be able to pick up these subtle substrates. And you need to do all sequences. So not just one T1 or T2, you need to do all the sequences in order to understand the exact location and anatomy of the lesion. So like I was saying, re-examine the MRI again and again. Discuss with the neurologist where the focus is likely to be based on video EEG and re-examine that area again. Never examine the MRI on films. You always should examine it on high resolution monitor. And above all, get a radiologist who's interested, because epilepsy substrate detection is not the cup of tea for every radiologist. They have to be specially tuned in order to detect such subtle substrate lesions. So this is a PET MRI co-registration, which we published in the year 2006, along with Professor Gary Mathen from UCLA. This was one of the papers during my post-doc fellowship. And now this has become a standard for our epilepsy surgery team at the All India Institute. Now, the second challenge is that whenever we listen to talks of epilepsy surgery from very advanced centers, we really get put off, because they would be showing so much of high technology. They would be showing post-processing, they will be showing the DTI, they will be showing all kinds of connectomics, and then finally they would be putting electrodes. And when you see, one does get overwhelmed. And that is precisely the reason why we need to develop our own protocols, which is customized to our own ecosystem around here. So in order to innovate this, it's very important not to compromise the MRI, because MRI becomes a keystone for you. In addition, we could also develop arterial spin labeling. For instance, over here, the MRI was initially reported as normal, but Dr. Manjari felt that most of the seizures was coming from right temporal lobe. And when we looked at it closely, we could see that this area is much more abnormal than this area. So you cannot see the gray-white differentiation. And when we did arterial spin labeling, which is available with every MRI machine, we could see this large area of temporal hypometabolism. And then, of course, it was reconfirmed by MEG. And using this, we could directly go ahead and do a large temporal lobectomy without any SCG or invasive EEG. So that's the reason why we need to optimize it. So this could have been easily diagnosed without a PET, only with an MRI and arterial spin labeling. It's important for us to minimize the invasive EEG. Now, when we listen to talks from, again, from various advanced centers in US and Europe, they would be putting in SCG electrodes. They say that they do not believe in electrocardiography. But fortunately, in the place where I trained, in UCLA, the center has been trained to be heavily dependent upon electrocardiography. And we soon learned the very good advantages of doing intraoperative electrocardiography. We now have experience with more than 1,000 recordings, and we published several papers. So it's very important to provide optimal anesthesia. Then we should grade the ECOG. We should do it both pre-operatively as well as post-operatively. For instance, in this case, a neurocystic when we put electrocardiography, there is area of resection was much more bigger. So when we initially resected a small area, the electrocardiography did not improve much. And then finally, after this final resection, it had completely improved and normalized. So we have been trained to do electrocardiography again and again following resection, especially for cortical dysplasias, till it becomes normal or till it has improved significantly as felt by the neurologist. Now, currently, we have stopped doing subdural electrodes and we only use stereoencephalography. And the reason is that it's very minimally invasive. And we use the French guidelines on stereoencephalography. And I will encourage you to read this very good paper, which has been, and my friend, Dr. George Dorfmuller is part of it. He has been to AIMS to help us with our SCG program. And when we see publications from various papers, so it is shown that SCG implants are sampled 20% more gray matter than the subdural electrodes, and the insular coverage could be only obtained with SCG. And the only disadvantage is SCG samples small areas, but that is why you require intelligent placement of SCGs. Now in this paper, SCG was found in this, beg your pardon? Are you able to hear me?
Yes, Prof.
Okay.
It's clear.
Yeah, and how much time do I have, Harry? Because I didn't.
Now it's you still have around 55 minutes, Prof.
Oh, thank you. Thank you very much.
It's still a huge time, Prof.
So now in this paper, SCG was found to have greater safety and efficiency benefits than SDE, such as low morbidity rates, low prevalence of neurological deficits, and shorter recurrence times. So some people have advocated the combination of both subdural grids and SCG, but in our experience, an intelligent placement of SCG has usually led us to find the area which we are interested in. And the reason is that it provides a three-dimensional representation. The electrode implantation is predictable, it's minimally invasive. And for me, one of the most comfortable factors as compared to subdural grids, which I used to do more than 15 years back, is that you could easily explant it in the ICU. So there are certain drawbacks of SCG. So one of the drawbacks is time required without robots. So if you're doing it with a frame-based system, it takes a long time, but I still think it's not such a major disadvantage. There is some challenge about language mapping, but more recently we have been able to map language using SCG, especially putting it in the language areas. And the best advantage of SCG is that these electrodes are very, very thin, just 0.8 mm. And when you put it, there is minimal risk of any bleed or any kind of hematoma formation, and the complication rates are very, very less. And the infection rates are also very less. In SCG, we just need to make a small opening and then take it out and just put one stitch. So it's important to develop a proper hypothesis. So one cannot go on randomly placing SCG everywhere in the brain. So a very good pre-implantation hypothesis has to be formed. And that is what we do. We do all the possible non-invasive investigations. And once we are sure that this is the area where there are epileptogenic networks, that is when we go with SCG. We do not go when all the investigations are completely discordant, which means that the MRI doesn't correlate with other investigations like PET, MEG, or whatever it is. And then you put SCG to find where the localization is. That is not going to happen. So you need a good hypothesis before you proceed for SCG. Now, one hemisphere should be preferentially explored, but if when contralateral electrodes are indicated, they should be placed as symmetrically as possible. Bilateral and symmetrical exploration with the same number of electrodes in both hemispheres is not recommended. Now, that means your hypothesis is not strong. So you could place a couple of some kind of a reference electrodes on the opposite hemisphere, but most of the electrodes only have to be on one side. Now, it's important to also employ primarily orthogonal trajectories to avoid angulation and avoid entry error. But again, when we are dealing with insula, you could also go with oblique trajectories, and this was described by Thomas Jefferson University by Ashwini Sharan. And we use oblique trajectories for insula. Now, this is how we manage. So we have an O-arm with the ROSA, and these are the instruments which we use. Harry is very acquainted with this because he used to put all the SCG electrodes. And you need to have a standard exploration pattern. So these are the standard patterns which we got from the French group when we need to place. But again, based on your hypothesis, you could customize your electrode placements. And at AIMS, so these are the insular trajectories. So rather than having orthogonal, we could have oblique trajectories which have an ability to cover greater area of insula. So in AIMS, we have made a book. So once we decide where exactly SCG has to be placed, we mark it on this paper, and then accordingly we plan the placement of SCGs. So these are some examples of temporal exploration, you have amygdala, anterior hippocampus, posterior hippocampus. Then similarly, these are some examples of frontal lobe explorations. Now I need to reiterate that 7 to 10 electrodes are the standard. And if you cross this number, you have likely to have lost your hypothesis. So after this, once the electrodes are placement, the patients undergo continuous video EEG monitoring, and the contacts, then we also should record a spontaneous seizure as per the known semiology. So if the patient has some other type of seizure, that cannot be called as an habitual seizure. So we should be able to record habitual seizures with SCGs placed inside. And then we can go ahead with stimulation. So stimulation could be low frequency or high frequency, and we can do both the frequency of stimulations. So most of the video EEG systems come with an inbuilt stimulator. So you could use that, it's very convenient. And interpretation is most important. So for example, if you have a focus here and the impulse is getting transmitted in this manner, so all the 3 electrodes placed here is going to pick up the signal. So you may actually end up resecting this area and leave the epileptogenic focus or the networks. Similarly, you could have focus coming from the opposite side. So that is why if you have any doubt of lateralization, you could place a couple of electrodes on the opposite side. And one should not hesitate to implant more electrodes if the data is sparse. So I'll show you a few examples. So this is a 15-year-old male, seizures in 7 years, 1 to 2 per week, aura of choking, throat constriction. So video EEG showed localization to the right side. So we thought query right MTA, something on the left side. So we were not pretty sure. MEG had showed on the right side. So we again implanted the electrode. And then finally, we were able to confirm that the activity was arising from hippocampus and from the right insula. And then we went ahead and resected, did an anterior temporal lobectomy as well as an anterior insular resection. And this came as type 1 focal cortical dysplasia, and the patient had a class 1 outcome. And there are similar papers which have been published in the literature. Now, in this case, SCG helped us to localize to the right temporal for resection. And it also allowed us to do a simultaneous insular resection, which we wouldn't have done without the help of SCG. Now, this is a 13-year-old female having seizures since 11 years, 40 to 50 per day. And you can see there is an insular focal cortical dysplasia. Now, patient underwent surgery 3 years ago by us only, but again continued to have seizures. So now in this case, we put some additional electrodes to see what is the spill of networks from the insular cortical dysplasia, because we couldn't find any residual cortical dysplasia on MRI. And using these extra electrodes, and then we stimulated these electrodes, and we were able to obtain habitual seizures. And then this localized the area to more posterior part, and we went ahead and did a resection, following which patient was completely seizure free. So this is the stimulation parameters. So in this case, SCG helped us to confirm the residual posterior insular FCD, which was not visible on MRI, but it was detected on SCG and then subsequent histopathology. Now, this is a 22-year-old male having seizures 4 to 5 per month, and he was having behavioral arrest. And you could see he had a cortical dysplasia right on the Broca's area. And this patient was very well preserved. So the parents did not want to have any kind of deficit for the patient. And when we did, the activation of the Broca's area was more or less on that place only. So in this case, we placed SCG electrodes on the cortical dysplasia as well as on the Broca's area. And by recording spontaneous seizures as well as stimulating it. So when we stimulated the electrodes on Broca's area, there was no speech arrest. So we were able to safely resect the cortical dysplasia, and the patient's speech was completely preserved following surgery. So I will skip the video. Now, can just show it since he says I have 55 minutes. It's not showing. It's okay. Now, in this case, SCG helped us to map language. So you can use SCG to map language. But thing is, again, you have to place them very, very intelligently. And these are the various papers which have been published. where people have done language mapping using SCG. And these are some of the relevant papers. Now, this is a 28-year-old female, seizures from the age of 15 years, duration 13 years, 1 to 3 per day, now 5 to 6 per week. So as you can see that the MRI was mostly normal. The MEG was also more or less normal. Ictal SPECT showed some activity on the right side, which was again correlating with the MEG. So this is a localization, I'm sorry, on the left side. So this is a localization. MRI showed query something in the left inferior temporal and temporo-occipital. PET was hypometabolism bilaterally. Syscom showed left inferior temporal localization. MEG again showed bilateral. So it's a bilateral temporal origin of seizures with cingulate gyrase and bilateral insular. That was the hypothesis. So here we placed electrodes mostly on the left side, but we also placed some electrodes in the insula as well as cingulate gyrase on the opposite side. And then as you can see using the recording, we found that the ictal onset was from the left basitemporal, and then it spreads to the rest of the brain. Similarly, stimulation also produced recording in the same area, going to amygdala. So in this, the semiology was bilateral left temporal. MRI showed now a temporal FCD. SPECT was left basitemporal. PET was left temporal hypometabolism. Spontaneous seizures also was left basitemporal. MRI SCG stimulation was also left side, producing habitual seizures. So we were able to do a temporal resection with amygdala hippocampectomy. Now in the hippocampus, it was spared because there was no activity noted on SCG, nor any habitual seizure was produced on stimulation. And the other important reason is because it's on the right side, immediate visual memory was also impaired. So we wanted to spare the hippocampus. So these are the spontaneous seizures which I had. I will skip this. These are the habitual seizures which the patient had. So she goes into a staring spell. Doesn't respond. And you can see some movement happening on the right index finger. Not able to name objects. Now this is on stimulation. And you can see these are the electrodes which were getting stimulated, from which we were stimulating and getting the response. So preoperatively, even though we had a very good hypothesis, when we placed electrocardiography, we got runs. So there was abnormality everywhere. So this is the Sylvain fissure. This is the superior temporal gyrus, middle temporal gyrus. It's on the left side. So we went ahead and did a lobectomy, but preserved the amygdala and the hippocampus. This is a superior temporal gyrus. And over this, when we put the CG, still it was abnormal. Even though it was, improved better than the last time, it was still grade 3. And then finally, when we removed the amygdala, that is when, immediately it became grade 2 and it improved very, very significantly. And our neurologists were very happy with the electrocardiography. The histopathology was FCD type 1 and patient had a class 1 outcome. So in this case, SCG helped us to localize the epilepsy to the left neotemporal amygdala and also left basitemporal. So we resected the lateral temporal lobe, and based on the electrocardiography, we also resected amygdala, and it also led to sparing of hippocampus. So you can see an intelligent combination of SCG as well as electrocardiography led us to a good outcome in this particular patient. Now this is a 21-year-old female, 10 years, 11 years duration, 1 per day. So these are the icters. The semiology was occipital, no localization. Video EEG, bilateral temporal, MRI right motor cortex with some flare intensity, PET is non-specific, SPECT again right occipitotemporal, MEG right parietemporal-occipital region. This is the fMRI which showed the motor strip. So we placed Caesars. Over here we were able to do high frequency oscillation measurements. And then this is the ictal onset which was coming. And then on stimulation, again we were able to, there was no response from angular gyrus, but when we stimulated the posterior temporo-occipital area, we were getting habitual Caesars. So the infracalcaline lingula, that is where we were getting the stimulation response. So this again is a spontaneous Caesar, and this is right lingula and right peripineal, and you can see the Caesar onset. So the patient turns to one side, she looks a bit uncomfortable. There is relative absence of motion on the right side. So now you can see that she becomes unresponsive. There's a deviation of the eyes to the left side.
ये कौन सा कलर है? कलर बताओ. इससे क्या करते हैं? ये क्या चीज है? ये क्या है? ये कौन सा कलर है? नाम बताओ. जीभ दिखाओ.
So not obeying commands.
कहाँ पर होगी?
And now they're injecting for ictal.
कहाँ पर होगी? नाम बताओ अपना. जीभ दिखाओ. हाथ बताओ.
And now she's responding. So that's how Caesars are. Very brief Caesars lasting only for a few minutes, and she doesn't realize what has happened. And then again, when we stimulated, so there is a head drop deviation of eyes, which is a habitual Caesar which happens. So when we stimulated the right lingual lateral, and this is the area we stimulated, and again the patient had an habitual Caesar. So even though we were not able to see, any abnormality on MRI, but SCG strongly pointed out to this area, both spontaneous as well as stimulation. So these are the eye rollings again, which is the habitual Caesars which happens. And the eye rolling, we were able to get when we stimulated the right superior temporal gyrus. So she had 3 types of semiologies. So that's why we were trying to recapitulate, we were trying to recreate all the types of semiologies. Now, on motor cortex stimulation, because there was a lesion in the motor cortex, we also put an SCG there. But when we stimulated, I'm sorry, let me go back. When we stimulated the motor cortex, she just had some painful dystonic posturing, but it did not precipitate into Caesars, which is expected. You know, when you stimulate motor cortex, you have dystonic posturing. So for her, it's very painful, you know, there's some kind of, but there's no Caesar which is produced. So now we stop the stimulation. So it did not show any activity from the motor strip. I know it was painful for the patient, but again, it helped us to confirm our hypothesis. So this is where we were able to localize. And as you can see, the preoperative electrocardiography was very, very abnormal. This is the orientation, anterior, posterior, lateral, medial. And this is the right angular gyrus, right lingual gyrus, right inferior temporal gyrus. And then we resected the posterior temporal and angular gyrus, but still you can see that there is abnormality. Now, after we resected the precuneus, again, there was significant improvement. And after resecting the inferior temporal gyrus, that is a place where we were getting the habitual eye rolling. You can see that the electrocardiography has completely normalized. So this is a final resection which we performed. And after also posterior hippocampal disconnection. So finally, we resected the temporo-occipital area, the angular gyrus, posterior to the motor cortex, and also the inferior temporal gyrus, and we also disconnected the hippocampus posteriorly, and then we found normalization of the electrocorticography. And this is the post-operative CT scan, which shows a large cavity. And the histopathology has come as type 1 cortical dysplasia once again, and patient was seizure-free. So SCG helped us, combined with electrocorticography, to dissect a wide area of networks consisting of right angular gyrus, lingula, precuneus, and posterior part of inferior temporal gyrus. I will complete with this last case. 30-year-old male, seizures, age of onset at 7 years, duration for 23 years, 2 to 3 per week. And you can see on multiple drugs. So almost all events happening in sleep. Figure of 4 with extension of the left upper limb and left lower limb, forced eye, head and eye deviation to the left, rapid secondary generalization. So the video EEG, localization to the central and frontal with slow sharps at F4, C4, T4, with TERDA at FP2 and C4 and T4. Localization was to the right posterior frontal and anterior temporal. So neuropsychology was intact. And when we did an MRI, we found the slight thickening of the cortex here, gray matter here. And we had a suspicion to believe that this was a focal cortical dysplasia. But when we did the PET MRI fusion, now we can find a very nice area of hypometabolism as compared to the opposite side. And this confirmed our diagnosis. And Syscos, again, was not contributory because it showed it on the opposite side. Now this is fMRI again, which we did. Localization of the motor strip. So in summary, the video EEG has a large area of activity, whereas the MRI showed a lesion in this place. Ictal SPECT was on the opposite side. So in this case, we implanted SCG electrodes, again, 7 electrodes in the right hippocampus, anterior to the FCD, posterior to the FCD, left posterior occipital sulcus, right superior temporal gyrus, which is area of PET hypometabolism, right parietal opercular, left parietal opercular, and then left parietal opercular. This is. So the ictal events was found coming completely from the area of focal cortical dysplasia, and on stimulation we were able to produce a habitual seizure. So fundamentally, a small area of focal cortical dysplasia was stimulating a wide array of networks, which was visible on video EEG, and possibly it was spreading so rapidly to the opposite side that by the time they had injected the dye, the SPECT was coming opposite on the opposite side. So one should remember that even if the SPECT is not localizing, even though if the SPECT is not localizing, but one should take into mind the rapid spread of SPECT to the opposite side. So if there's a pathology on the contralateral side, then SPECT does not actually become discordant. Now, in this case, what we did is we did a very unique surgery. So we burnt the SCG electrodes using radiofrequency ablation because he was very well preserved. And that is how we did. And this burning was done on the bedside. So you can see how there are special SCG electrodes, and this is egg white. So when you put it and burn it, you can see that how the egg white is coagulated. And we use this special stimulator as well as recorder for burning the electrodes. And this is a Cosman generator which we use for burning these electrodes. And this is done completely by the bedside. So basically, it's the neurologist who's doing surgery. So we use a generator here. And when there is a sound of a pop which happens on auscultation, which means that the burning is complete. And the patient should be counseled for that you will hear some popping sounds in your head. And you can hear the sounds even without stethoscope. And you should not get afraid because of this. So this is a literature on SCG guided thermocoagulation, which has been published by the French group. Now, unfortunately, this patient was seizure-free for some time, and then he came back again with seizures, and we had to do open surgery. But it gave us a very good learning experience. And in this case, SCG helped us to localize a focused group of networks. So even though we did a second surgery, we were very sure that this was the area because it was histopathologically confirmed. So if you look at the outcome of SCG guided radiofrequency ablation, the outcomes are quite reasonably good in the literature. And the current the current recommendation is that one should do SCG guided radiofrequency ablation if you have a very focused hypothesis and you feel that you will be able to eliminate that. So this is definitely not for large cortical dysplasias. So concluding for SCG, invasive EEG is indicated for proving the concordance if the non-invasive investigations are inconclusive, identifying subtle lesions, localizing networks. We now perform SCG followed by intraoperative electrocardiography to customize resections. SCG in our experience has been safe, minimally invasive, low risk of infection, easily explantable, good for eloquent areas. And planning should be based on a valid hypothesis where SCG would help you to prove a hypothesis. So it's unlikely to create a hypothesis. You cannot think of creating new information from stereoencephalography. It is something to confirm the information what you already have pre-resection. We go to the third topic, which is to counter, what are the strategies to counter the technology overuse? So it's very important for us to innovate the pre-surgical workup to minimize the invasive EEG. Our standard electrode placement is somewhere around 6 to 7. And with 6 to 7 SCG electrodes, we have been able to manage very well. We're getting good outcomes. So it's unlike the 14, 15, 16 electrodes which the other centers use. So we go in with a full preoperative workup and also with a good preoperative hypothesis. So it's important to innovate strategies, surgical strategies. So in that respect, we have described endoscopic hemispherotomy, which is a surgery from a very small opening. And you can see Heri Subianto's paper in these papers. And then I will now show you just a short YouTube video. Is it audible? This video demonstrates the technique of performing vertical endoscopic hemispherotomy using the is the video audible? Corridor. And visible?
Yeah, it's visible, bro.
A 12-year-old right-handed girl with seizure onset at age of 10 years had a frequency of 15 to 20 seizures a day. She presented with an aura of fear and nausea followed by tonic deviation of the eyes to the right side and blinking with speech arrest. There were tonic-clonic movements of the right side with ictal spictane and occasional deviation of the angle of mouth to the right side associated with loss of awareness. Over a period of 2 years, she also started having epilepsia partialis continua involving the right hand. Examination revealed right-sided hemiparesis with loss of pincer's grasp. Video EEG revealed left parieto-central and left temporal localization. She received methylprednisolone with transient benefit considering the diagnosis of Rasmussen's encephalopathy. She was on multiple anti-epileptic drugs without any benefit of seizure freedom. Neuropsychological assessment revealed global impairment, including visual and verbal memory functions. MRI revealed widened sulci on the left side, predominantly involving the perisylvian region. There is an associated left lateral ventricular enlargement with hyperintensity on the left extreme capsule on fluid attenuated inversion recovery images. Similar findings were noted on T1 weighted imaging. These changes were progressive as compared to the MRI performed 3 years prior, suggestive of Rasmussen's encephalopathy. SPECT and positron emission tomography localized to the left frontal and the left frontotemporal hypometabolism respectively. Functional MRI revealed good representation of the left hand area over the right pre- and post-central gyri. Speech and language and memory showed bold activation localized bilaterally to both the lobes. The endoscopic approach provides an inverse funnel-shaped expanded panoramic view. Under general anesthesia, The patient's head is fixed with slight neck flexion by about 15 to 20 degrees. A 5 centimeters transverse incision, 1 centimeter anterior to the coronal suture is given, followed by a 3 into 2.5 centimeter semicircular craniotomy fashioned with the base towards the midline and apex laterally. After opening the dura, the endoscope is brought in the field and the interhemispheric fissure is opened meticulously using sharp dissection. The cingulate gyrus adhesions, as seen in this case, should be released so as to reach to the corpus callosum. Recognizing the pearly white corpus callosum along with the callosomarginal and pericallosal arteries is crucial prior to the beginning of corpus callosotomy. The exposure of corpus callosum is continued from the body till the genu, where both the A2s and ACS dip inferiorly. At this stage, a roll of spongestin or gel foam is placed along the genu, which facilitates the atraumatic dissection by expansion owing to its hygroscopic nature. The exposure of the corpus callosum is then continued posteriorly till the splenium. Once complete, the callosal sectioning is commenced. It's crucial to maintain the callosal sectioning ipsilateral to the side of hemispherotomy in order to enter the ipsilateral lateral ventricle. The corpus callosum is continued anteriorly till the genu, maintaining the same plane till the ipsilateral frontal horn. It is important to preserve the anterior commissure during this procedure. The anterior disconnection is commenced. We prefer to perform this step extraventricular anterior to the frontal horn with the use of navigation guide during this step. The basal arachnoid after resecting the gyrus rectus is exposed and the line of dissection is then carried out lateral to the head of caudate nucleus. Exposure of the basifrontal arachnoid ensures the completeness of anterior disconnection. Care should be taken to preserve the olfactory tract subpially. The middle disconnection is continued till the sylvian arachnoid has the inferior most limit with sphenoid ridge transition of the anterior to middle cranial fossa serving as a fixed landmark. The goal of middle disconnection is to connect the lateral ventricles to the temporal horns so that they form the same cavity. The choroid plexus of the temporal horn serves as an important landmark at this stage. Once the temporal horn is exposed, the amygdala and the hippocampal head are resected. During the middle disconnection stage, bleeding is encountered from the lenticulostriate and the thalamostriate perforators. Therefore, use of variable impedance bipolar coagulation forceps at higher coagulation settings is very useful. It is also important to disconnect the temporal stem anterior to the hippocampal head. The middle disconnection is carried out posteriorly, lateral to the thalamus, following the temporal choroid plexus till the atrium of the lateral ventricle is reached. Once the middle disconnection is complete, the posterior disconnection is performed, which consists of splenial disconnection. It is vital to carefully disconnect the thick bundle of the splenial fibers till the arachnoid of the quadrigeminal cistern is visible. This is followed by phoneal disconnection, which completes the hemispheric disconnection. Therefore, hemispheric disconnection preserves the diencephalic structures, which are left intact and connected to the normal hemisphere, while the rest of the affected hemisphere is isolated. Once disconnective procedure is completed, thorough irrigation of the operative cavity with warm saline in order to adequately evacuate the blood products is performed. This could be later responsible for prolonged postoperative fever in some of the patients. The cortical subcortical tissue biopsy is performed for histopathological confirmation of diagnosis. This is followed by water. Let me go to my presentation now. So I can see that the time is 10. So I will show a short video on posterior quadrant disconnection. And this would be the last video, because these are, really challenging surgical procedures. So you can see that this is the lateral anterior posterior, and this is the distal perisylvian vein. This is the lateral sylvian fissure. So posterior quadrant disconnection involves connecting doing a TPO disconnection. So the temporal parietal occipital area is completely disconnected. So we first to do motor mapping, and it is very, very important to do this because in one of our earlier cases, we had patient developing a deficit. So we always map the motor cortex. And then first we start with temporal disconnection along the superior temporal gyrus. And then we expose the insula. These are the parietal opercula and the temporal opercula. Now defining the inferior and the posterior limiting sulcus of the insula using navigation guidance to perform a complete temporal disconnection. Now we are opening the inferior limiting sulcus. Now we are entering the temporal horn. Exposing the entire temporal horn. So once you expose, it's important to resect the amygdala and the hippocampal head because the amygdala is connected to the brain through dorsal amygdala. So we start with the lateral hippocampal disconnection. And resecting the amygdalar head. So this is uncus being stripped off from the arachnoid. And we use a number 1 Penfield dissector to do the same. We trace the temporal horn posteriorly and disconnect the hippocampus at the head-body junction. So this is the anterior disconnection of the hippocampus. Hippocampus is actually not connected to the opposite side, but since it's such a close proximity to the amygdala, so there's a reason to believe that hippocampus could always be a part of the epileptogenic networks, and that's the reason we always resect the anterior part of hippocampus whenever we do hemispherotomy or we do a PQD. Now we are doing a parieto-occipital disconnection. Now we're connecting the parieto-occipital and the temporal disconnections. And now we are exposing the atrium of the lateral ventricle. Now we expose the falx medially and then start resecting the medial wall of the ventricle along the atrium. So now we have disconnected the splenial fibers. So we have done complete splenial disconnection. Now the hippocampal tail, which is continuing as fornix, has also to be disconnected, because if you don't do that, there is still connection with the opposite side. So then we disconnect the hippocampus. Now at the end of surgery, so you can do a post disconnection stimulation and the motor strip is intact. And as you can see the line here, we have done a complete TPO disconnection, and this is how it looks like. So this is a big advantage rather than physically trying to remove the temporo-occipitoparietal area, which again can lead to large cavities and its problems. So it's the same video. So we also described endoscopic corpus callosotomy with commissurotomy. This is the paper. Then of course, the robotic guided radiofrequency ablation of hypothalamic hematoma. And you can see Harry's paper, Harry's name in this paper, which we published first. So endoscopic minimally invasive surgery was for hemispherotomy was started by us, and that led to an emergence of the important role of endoscope in epilepsy, and we published this paper some time ago. Our latest innovation has been ROCH, which I would not describe too much here because that's a complete topic by itself, but it's a bloodless method of doing hemispherotomy where instead of doing an actual surgical disconnection, we pass intelligently electrodes using a robotic system in such a manner so that we can perform hemispheric disconnection. Now, this is the last video I like to show because of its interesting thing of the challenge it presented. This is an MRI negative pathology. So Harry's name is here also.
This video demonstrates the technique of SEG electrode insertion and our approach to a patient with MR negative epilepsy. A 28 years young lady with a seizure duration of 13 years presented to us with predominantly two types of seizures. One was associated with an aura of chest discomfort and palpitations. There was history of automatisms involving bilateral hands, followed by a speech arrest. There was a consistent history of ictal urinary incontinence. The other type of seizure was associated with head turn towards the right side. This was followed by secondary generalization. She was on 3 anti-epileptic drugs, started over the course of her illness with an appropriate dosing. Video AG revealed rhythmic slow and sharp wave discharges in bilateral frontotemporal channels, followed by polyspike and slow waves in the same region, seen prominently on the right side. In this slide, a spike can be seen in the FP2-T2 channels just prior to the rhythmic theta activity predominantly, but also can be seen in the FP1-T1 channels. This is followed by progression of the seizure in bilateral anterotemporal regions. This slide shows further progression of the seizure. Multiple events were recorded, which were consistently similar, with seizures arising from FP2T2 as well as FP1T1 channels, suggestive of a bilateral temporal onset of seizures. MRI brain performed under epilepsy protocol did not reveal any focal lesion and was reported as normal.
So MRI was normal here.
With this background, she was further evaluated with PET scan, which showed a left anterior temporal hypometabolism. Subtracted SPECT co-registered on MRI showed lighting up of the left basitemporal region. On further evaluation with magnetoencephalography, the Dana sequence showed tight clusters in bilateral temporoparietal region. The Loretta sequence localized to the left temporal lobe. Functional MRI to assess the language function showed bilateral representation of Broca's area. Both the memory and comprehension showed bold activation predominantly on the left side. Neuropsychological assessment showed grossly impaired visual memory. There was also impaired immediate recall on verbal memory, suggestive of predominant right temporal involvement. Predominant left temporal localization was noted on clinical semiology, PET and SPECT scans, as well as magnetoencephalography. While video EEG and neuropsychological assessment showed a predominant right-sided temporal localization. Possibility of insula and cingulate cortices were also considered in view of ictal urinary incontinence. Following the comprehensive epilepsy surgery meeting, placement of 12 SEG electrodes were planned, covering the anterior, middle, and the posterior temporal lobes, encompassing both the lateral neocortex as well as the nasal structures, including the amygdala and the hippocampus. An additional left basitemporal electrode was planned based on the SPECT finding, along with bilateral cingulate and insular electrodes. The patient is positioned supine, head is fixed with a Mayfield clamp and attached to the robotic arm to achieve a rigid fixation. Alternatively, Lexel frame G can be used as a head holder, which is ergonomically better than the Mayfield clamp, as it allows free space without hindering the movement of the robotic arm, especially if bilateral temporal electrodes are planned. A 3-post fixation of Lexel frame may be useful if skin-based laser registration is performed, which is otherwise not required in case of bone fiducial-based robotic registration. We routinely use skin-based laser registration, which begins initially with a 6-point facial registration. This is followed by the mesh registration, covering the nose and the forehead region, followed by zigzag laser scanning of the forehead, and then subsequently manual scanning of the bilateral temple regions. After the registration is complete, the accuracy of the registration is checked by pointing the laser to all the 6 points. The aim here is to attain a minimum error. If the error is more than 1 millimeter, then the points can be manually adjusted to correct it. In case of persistence of the error, re-registration should be done. The robotic arm is driven to the desired trajectory, and the entry point is marked as per the laser pointer. The patient is draped as per the marked entry point. A 2.1 mm twist-drill craniostomy is performed using a pneumatic handheld drill by directly drilling through the scalp without a stab incision. A stopper should always be fixed at a distance equal to the scalp and the bone thickness measured on the robotic platform so as to prevent inadvertent
So we don't put
entry
any
into the
skin
brain
incision.
parenchyma.
So we drill
An
directly
important
into
pearl
the
here
skin.
is to place the robotic adapter closely opposed to the scalp in order to avoid any play of the drill bit, thereby avoiding cross deviations. While drilling, the surgeon can very well appreciate resistance initially representing the outer cortical bone, followed by a giveaway field denoting entry into the diploic space. This is again followed by a resistance suggestive of inner cortical margin and a final giveaway suggesting entry into the epidural space. This is followed by dural coagulation using a monopolar cautery. Now the anchor bolt is tightened into the drill craniostomy using a set screwdriver till the good bony purchase is appreciated. Following this, the stopper is tightened opposing the top of the robotic adapter, and the distance to target, that is the distance A, portrayed on the robotic screen is noted. Distance P is measured as shown in the video. It is imperative at this step to avoid moving the robotic arm till the insertion of the electrode is complete. The length of the SEG electrode to be implanted is calculated by negating the distance B from A, also minus 3 mm, to account for the 3 turns of the cap over the anchor pole. A variety of electrodes are available commercially, capable of simultaneous recording, stimulation, and radiofrequency listening if required. The appropriate length of the electrode is then inserted through the anchor bolt. And the cap is tightened over the bolt snugly. Following which, the stylet is pulled out. And final tightening of the cap is done, which not only secures the electrode, but also prevents a CSF leak. We routinely perform warm spin after the first electrode placement. If the placement is found satisfactory on merging, subsequent electrodes are placed without confirming on warm CT. After all the electrodes are inserted, a thin slice 3D CT scan of the brain is performed post-operatively, which is then merged with the pre-operative MRI, and the trajectories are matched with the electrodes implanted. The patient is monitored in the ICU till at least 3 to 5 seizure recordings are noted. We also perform stimulation of the electrodes to confirm the findings. The spontaneous seizures recorded reveal discharges arising from the left anterior, middle, posterior basitemporal, and amygdalar contacts. No discharges were seen in the hippocampal contact. Similar findings were noted on stimulation of the electrodes. Based on the SEG finding, hippocampal sparing ECG guided resection of the left temporal neocortex.
So we did so this MRI, as you can see, was completely normal, but with the SEG and good preoperative hypothesis, we were able to do a seemingly normal temporal lobe resection, following which patient was seizure free. And the histology was that of a cortical dysplasia, type 1 cortical dysplasia. So there's a video for VNS. So Harry, if there is no time, I would like to conclude. Is that okay? Because I think I've been going on for too long. Or if you're interested, I can show the video on VNS. Both the ways are okay with me. It's depending on your comfort and your schedule. Harry? Hello, Harry, can you hear me? Am I audible?
Yes, Prof. We still have 5 minutes. 5 minutes before closing.
Okay, good. So I will now conclude. So the last two challenges are inability to sustain programs, manpower training. So it's important to create a good seamless collaboration. And it's also important to speak to the regulatory bodies for subspecialties to expand beyond undergraduate programs, create fellowship programs, avoid conflict of interest between various subspecialties. So there should be rotation of residents to all the subspecialties. So concluding, the lack of treatment and delay in referral should be tackled by creating national programs and hub and spoke referral. So we have to create a lot of public forums in which we can make neurologists aware the efficacy of epilepsy surgery. So that is an important responsibility of neurosurgeon, followed by the entire team. And I will strongly encourage Harry to also do the same. Now, lack of diagnostic resources can be made up by optimal use of MRI imaging like I've showed you. Now, ultra high technology, which is propagated by advanced countries, can be mitigated in many cases by simplifying the preoperative workup and again re-examining the MRI, making your MRI of good quality, and also reducing the number of SCG electrodes like we have by creating a very good preoperative hypothesis. It's difficult to sustain programs unless there is support from the administration. So the administration has to support us for creating a good epilepsy surgery program, because it's not just doing surgery, but it is creating an environment where everybody is excited about contributing towards this, because it's not just one man's work. You know, there are so many people who are associated with this. So I would like to thank all my co-faculty, staff and residents. There are so many of them in the COE. I cannot name all of them individually, but yes, at this point of time, I'd like to thank the senior most people, Dr. Manjari Tripathi, who has been the core leader for this program. She literally drives the epilepsy surgery program. So if we do not do at least 3 cases a week, she becomes very upset. And I think that is how the neurologist should be. Professor C.S. Bal, who is from the head of the nuclear medicine department, who provides us ICTL, SPECT and PET. Professor Sailesh Gaikwad from neuroradiology, along with Professor Ajay Garg from neuroradiology, Professor M.C. Sharma from neuropathology, Professor Madhavi Tripathi, again from nuclear medicine, and Dr. Ramesh Doramani, who is a very good colleague of mine and picking up epilepsy surgery well, Dr. Senthil from FMRI, Ashima from the clinical psychology, and Dr. Jyotirmay Banerjee and Dr. Aparna Dikshit, who are our research faculty. And of course, we have Dr. Bhargavi, who is a faculty now. And these are our 2 new fellows, Dr. Nihal Ahmed and Dr. Ravi Chandra. So with this, I would like to conclude my lecture. And once again, it has been a great honor and a pleasure for me. I know it's quite a distant learning, so we cannot meet physically, but we soon hope that the COVID pandemic will be over and we will be able to visit you, and vice versa. I invite all of you to also visit us. So, Tarima Kasi.
Thank you so much, Professor Poodipedi Sarat Chandra, for the excellent lecture and very inspiring lecture. Due to limited time we have, now with us, we have Professor Abdul Hafid Bajamal, our professor in Department of Neurosurgery, Airlangga University. I asked Prof. Abdul Hafid Bajamal to give some speech. Prof. Please, Prof.
Yes, good afternoon, Professor Sarat Chandra. Thank you very much. First of all, I congratulate for your position now as Adjunct Professor of Airlangga University. Thank you very much.
Thank you.
And the second is your quote about the cheese. Yeah. Old cheese will smell different. So you have to go and move to new direction, to find a new direction, and don't be afraid, and you will find new cheese. That is a very inspiring quote. Thank you very much. And first of all, I would like to thank you and appreciate for your contribution and help and support for our department, our faculty, and my staff. This is really very much support from you. Thank you very much. I hope in the near future we can make a good collaboration, that many of my staff of Indonesian neurosurgeon can learn from you in your department. And that is very important, not only for epilepsy, but also for another field. That is, thank you very much. And thank you for all. And I hope our collaboration still, our relationship still continue for the next
next future. My question about the presentation about epilepsy, you mentioned about a national program. What do you mean with national program? Is it training or also in management of epilepsy? Thank you very much.
So thank you so much, Professor Bajamal. It's really very nice, even though we are speaking on the net. I see, Harry, am I audible? I see Professor Bajamal's image is frozen. So now the national program, when we say national program, we mean that 70 to 80% of the epilepsies can be treated at a peripheral center or at a smaller place. They do not have to be referred to a tertiary center. The only problem comes is because the physician doesn't know which is the proper drug to be used. So for that, we created something called as GEMIN guidelines, which are guidelines of epilepsy management of India. It's available online and booklet, and it's a small booklet which shows you what is about epilepsy management. Almost 50 to 60% of the physicians are not aware of proper pharmacotherapy. They're not aware of various combinations, not only among anti-epileptic drugs, but also its interaction with other medicines. For instance, if you're taking AEDs, there are certain antibiotics you should not take. So all this has to be, should be very much aware with the physicians at the lower level. Most often, the so-called drug-resistant epilepsies which are referred to us are actually cases who do not have proper compliance, or they're taking improper medicines. So basically, it's a pseudo-refractory epilepsy. And that's the reason if we start this program right from the grassroots level, only the most difficult to treat drug-resistant epilepsies will then be referred to a tertiary center like Surabaya, and then Harry will be able to work it up properly and then do a very good job for epilepsy surgery. And at the same time, this program is essential for everybody to be aware of, aware of the nuances of epilepsy surgery. People think it's a last thing to be done. It is not. It should be done very early in the course of disease. So once you fail 2 drugs, it's a drug-resistant epilepsy. There's no point giving a ton of other drugs because they will not going to work out. And the chance of drug-resistant epilepsy being treated by medicines is close to 0%. So this fact has to be made aware to everybody. Also the fact that if you do not treat epilepsy, the networks are going to expand. So when you do surgery, 10 years later, you're not going to have good outcomes. So that is a whole principle behind setting up a national program so that everybody is aware about the treatment of epilepsy and epilepsy surgery.
Professor Jamal and Professor Sarat Chandra. So right now we are almost at the end of our time for expert lecture. We hope that this pandemic will end soon, and we can visit you again, Professor Sarat Chandra. It was very nice. I spent 1 year in AIMS, learned so many things from you, including how to build epilepsy center. We start here with a simple case, temporal lobe epilepsy, and then we also make our MRI. We fuse with arterial spin labeling and all, and we hope that we can continue this. And regarding the research also, from now we can working together as a team. We hope that we can send some other staff and our resident to visit AIMS, and also resident of AIM can also come to us to learn together more on neurosurgery field. With your support, Professor Sarat Chandra, and also from our Professor Abdul Bajamal, and all the staff member of the neurosurgery department and Airlangga University. Now it's time for me to give this event back to Dr. Sasa. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh.
Check. Thank you, Professor P. Sarat Chandra, MD, for the knowledge that has been given to us. And thank you, Dr. Heri Subianto, MD. And also thank you, Professor Abdul Hafid Bas Jamal, MD, PhD. Ladies and gentlemen, that was our last agenda for this special event. May what we have conducted today will be useful to all of us. Thank you very much. I hope we are staying safe and healthy. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Prof, of our inaugural ceremony.
Thank you very much. And we will hopefully meet sometime. Bye-bye.
Bye-bye, Prof. See you next time.
Yeah, see you next time. And Dr. Manjari is here. She can say hi.
Oh, Prof. Manjari, how are you?
Hello.
Hello, Prof.
Hello.
Nice to see you, Prof. Manjari.
Okay. Bye-bye.
Bye-bye.